Good afternoon and welcome to Symposium, Evolving Bifurcation Treatment Practices, Drug-Coated Balloons, Angio-based FFR, and Side Branch Optimization. 3 hot topics discussed in several other sessions from different perspectives. And now I would like to introduce first the panel. We have stars in the panel. It's Jens Flensted Lassen, Peter O'Kane, and Bon-Kwon. And I would like to invite the first speaker, Kambis Mashayekhi, to discuss Prevail clinical data.
Yeah, thank you very much, Goran. Thanks for the invitation. So, I'm just waiting for my slides. There we go. Okay. Yeah, so there are some clinical data out about Prevail from the SCAAR registry, and we will have also a trial, EBC DCB trial. I think it was well discussed already. Those are my disclosures. So yeah, we use the drug-eluting balloon therapies nowadays not only for chronic total occlusion, but also for acute chronic syndromes, and more also for patients with multivessel disease and diabetes with high morbidity of plaque burden, where we think that there might be high TLR and stents. So as you know, I'm a CTO operator and focusing as well on drug-eluting balloons in the CTO registry. It was quite interesting to see that increase from 3.4% in 2016 up to 14.9% now in 2023. And what we saw here in a very large registry of over 40,000 patients is that DCB was associated with shorter drug-eluting stent length for sure in the hybrid approach, for lower contrast volume and lower pericardial tamponade rate. So it seems to be also quite safe. For sure we have to look as well on the long-term outcome data regarding MACE. The trials that are going on with Prevail for now, we have data from the Swedish SCAAR registry. There is a Prevail global study going on in US and Japan and Europe, comparing a DCB strategy in small vessel disease and the upcoming trial from EBC DCB trial. And I will focus on that for short, only to see the flow chart. There will be 750 patients enrolled with DCB only versus a stepwise professional stent approach with the Onyx stent. The primary endpoint will be 1 year to combined endpoint with cardiovascular death, MI, TLR. And yeah, I'm very happy that the PIs as well, and Bruno Scheller and David, they focused on a really a straight DCB strategy compared to a stepwise approach. So that wasn't discussion up front, but I'm happy that we'll see a DCB only arm. So regarding the SCAAR registry, we have data from 1,800 Prevail DCBs versus 5,600 other DCBs and 2 years follow-up. And we've seen low event rate in the complex real world with Prevail, which is quite nice. The all-cause mortality is quite good compared to other drug-eluting balloons. For sure, this is not a randomized trial, but when we look at the bifurcation arm, we see that there seems to be a little bit, a shift towards that the Prevail might be superior compared to other drug-eluting balloons. We know the crossability is quite good from this balloon, and for sure we have a broad interconfidential interval, but nevertheless, it seems to be going in a good direction. So therefore, we are very happy that Medtronic is also supporting this trial for the bifurcation study. So let's look at the bifurcation sub-registry from the SCAAR. And we have 460 patients treated with Prevails compared to 1,000 patients with other drug-eluting balloons. Basically, the baselines are almost similar regarding diabetes mellitus, regarding acute coronary syndrome, multivessel disease, and also lesion characteristics. There might be a little bit of shift towards more calcification, moderate calcification in the other DCB arm compared to the Prevail arm, but the sphere calcification was similar, and there were low event rates again in the Prevail arm. As you can see here, new myocardial infarction, it was adjusted 2.3 versus 3.7%. Also low target revascularization, also adjusted 2.8 versus 3.4%. Yeah, happy to see that we didn't have any thrombosis, acute thrombosis, which is also important to see here. And so the key difference basically between hybrid PCI and DCB only was characterized here. You see the DCB only arm basically Prevail versus other DCBs, a little bit slightly more instant restenosis treated in the other DCB arm compared to the Prevail arm, and that resulted overall in an adjusted low TLR rates for Prevail across all the sub-studies, meaning bifurcations with DCB only, and bifurcation treated with hybrid PCI. And as well, low MI rates. For sure, no randomized trials, but nevertheless gives us a good feeling regarding safety profile of this balloon. So let's see about some cases. So I was asked to show also cases. This is a quite interesting case of acute coronary syndrome with a distal bifurcation lesion. So what we did is to restore flow, we dilated and then put a stent in the proximal part. You see a big stent, 3.5, which is, I think, also state of the art nowadays. And still you see the remaining distal lesion that you think should be treated or maybe could be left alone. So we decided for scoring angioplasty there and Prevail in kissing balloon technique. And this is how it looks like in the primary outcome. So you see the posterolateral branch doesn't look very good. It's a TIMI2 flow, but we did nothing after the drug and the scoring. We leave that without standing, and you see the 9-month follow-up is quite good, right? The vessel restored even in the PDA, and we have a quite nice result. So a post-cabbage bifurcation lesion was already tried to treat in another hospital multiple times, but it could not cross the lesion with angioplasty. So we rotablated over the graft, as you can see here. The patient was on angina, and then it did a kissing balloon angioplasty with 2 Prevails. The crossability was quite good here. You see still a calcified nodule on the bifurcation. We didn't force to rupture here, so we accepted that in a relatively small side branch. And this is how the primary result was. But on the left system, we also had a subtotal left main stenosis. And as the patient was in therapy, refractory angina, we decided to use the burr to do an angioplasty and also use a Prevail there. And this is how it looked like. Suboptimal result with dissection. We didn't put a stent here, and this is the 12 months follow-up, as you can see here. So the bifurcation is well preserved, as you see, with 2 DCBs after the graft. So this is quite nice after 12 months. And as well, we have a good flow in the left main, and the patient was symptom-free, so no stent necessary here. So another example with a hybrid concept. Here you see a proximal calcified circ lesion, and it's a big vessel there. But distal, we have also a bifurcation lesion as well. So we rotablated, dilated, put a big stent, 3.5, distally, single DCB, so we didn't need to do a kissing there for the distal branch. And the LED was also occluded, as you can see here. This is also a stent in a diagonal, so and so we had to open the LED. We did a DCB towards the LED. You see a remaining dissection, and that was left like that. And this is the 6-month follow-up. As you can see, the stent 3.5. We have good data for that. It's quite open, but distal. We used a free zero drug-eluting balloon. It's beautiful in the circ, and as well, we have a good result, I think, in the LED, only with DCB strategy. Final a case which I want to show you is a multivessel disease, surgical turndown, and a case which was attempted already in another institution with this circ. The problem was that I couldn't wire the circ, so it was a very calcified plaque, as you can see here. And you see the wire went in a subintimal space, and I did a angioplasty, kissing angioplasty. You see the nodule proximally, so I had to stop at that. That was in March 2023. 5 months later, the patient came again with angina, and despite optimal medical therapy, and you see the problem. There's still the high-grade stenosis. There's an instant restenosis, unfortunately, as you can see on the stent outflow of the circ. And here we treated again the main branch with a high-pressure open balloon, and the bifurcation again with DCB. So only DCB, no plaque modification was done after 5 months. So this is how it looks like. The patient came back again, and this is quite interesting, 22 months after the first attempt, again with angina. So here, at that time, the stent is endothelialized, the vessel is already healed. We know that from data that after 6 to 12 months with a completely healing of the vessel, now I was able to be aggressive, which means I rotablated that, which was the extra plug scenario in the past. Then I used the shock wave, and I used the open NC, so high pressure, 3.5 shock wave, 40 atmospheres in this eccentric plug, and finally achieved a quite very good result. Sorry that I could not show it. Here, maybe we can see it. Oh, it's not running. But the result was very nice, and this is a stepwise approach in a scenario where I'm quite sure that the stent would have failed. So summarizing, I think we have quite very good data for the Prevail, and we are happy that Medtronic is supporting the EBC DCB study. Thank you very much.
Thank you, Kambis. Great presentation, and congratulations on accepting article on CTO in JACC interventions.
Yeah, thank you.
I saw that you use kissing with 2 DCBs. Is it a strategy for all distal bifurcation segments to avoid stenting, or when you use it in the setting of bifurcations and CTO, what is the strategy that you would recommend?
Yeah. Well, it's a good question if you should do it sequentially or not. I mean, maybe also depends a little bit on the plaque burden. You don't want to have plaque shift, right? So the experience, first of all, it's faster if you do the kissing, and I think we can go with kissing, right? If the plaque is well prepared, but I think it's also important to score, right? So in many scenarios, the scoring is creating a limited dissection, scoring or cutting, and not an uncontrolled dissection. So whenever it comes to calcium, I think rotablation, scoring, and DCB is a quite good option for the patient in the distal disease.
Yeah, sure.
Right?
This proximally you stent occluded.
Yeah, because 3.5 I have perfect data for that, right? And I have to wait for other data, which will come.
Yeah,
I think.
Dr. Harp?
Is this going? Yeah. This was excellent examples, I think. You had a subtotal left main, then you showed us hybrid proximal vessel, distal vessel. I wanted to ask you, what is so different in the proximal vessels and in the distal vessels that can you speculate why stent works better proximally, or is it just that we are not there yet with the data?
Yeah, I think first of all, we're not yet there with the data, and we have excellent data. We have to say, when we see vessels 3.5 with new plaque modification therapy and the stents that we have, the data are very good. It's very hard to compete, and we've seen that in trials as well, right? When you look at the Chinese study now, which came up, so where DCB were inferior to especially on 3.5, right, and vessels more than 3. So we achieved already non-inferiority in basket small. But still we have to wait for data in the big vessels, right?
Short question, Peter.
Beautiful cases, Kambis. Just one quick question. Is there any sort of feel that you have as an experienced operator for when you would want to use paclitaxel like with Prevail versus the Lima strategy? Any subsets?
Yeah. Honestly, when I have a very, very long diffuse LAD, for example, very long diffuse disease, and maybe the runoff might be a limitation sometimes if you have on a poor distality, a very long paclitaxel treatment, which means probably 2 30-millimeter balloons, it might be then you end up in a slow flow or even no flow. And then sometimes people overreact and go for stenting, and then you might end up even in a slow flow or no flow in the stent, and that's what you should avoid. So in these scenarios, very small balloons, very long disease, distal disease, for now, I feel a little bit more comfortable with sirolimus, but we have also to wait for data regarding that, because the crystals is making something, right? And so, yeah, you have to be aware for that potential risk.
Yeah. Thanks, Kambis.
Yeah.
So next presenter is Francesco Burzotta, and tackling the challenges of ostial left circumflex stenosis.
So it seems that this is the EBC dedicated to that topic. We are once more here to discuss this problem. I will share with you 2 cases happened in our lab. 001 lesions can be found in many coronary artery spots, but when you have big circulations like that, it is very common that the patient comes in the lab due to this, so you have to do something. So how to manage this kind of lesions? We discussed it a lot. If we review the literature, we should recognize that anyway they are treated by PCI in less than 5% of the cases. These are the two largest registry we had so far. But if we explore the measured adverse events, this is at 1 year follow-up in this study, and in the other one it is a longer follow-up showing that the highest rates of adverse events are in this subgroup. So this is coming up with a challenge for us. They are rare and we have no established way of managing. Indeed, if we review all the MADS classification, what we can speculate that if we want to embark in stenting, we can do the ostial stenting and the inverted provisional. If we compare the two strategies for ostial stenting, we know very well that it really needs a favorable bifurcation angle and probably a supernatural precision in delivering the stent that with the beating heart is really, really rare to be achieved at the end. So for this instance, at least in our cath lab, we are using more and more the inverted provisional, and indeed it works well. However, it mandatorily requires intervention to the proximal healthy main vessel, namely the left main when you have this kind of lesions, and this is disappointing. And the other point is the fact that you have the LAD jailed, so you need to fix this in the interest of the patient and the future history, opening up the struts, and in doing this you may end up in problems for the LAD. So, however, what we are actually doing, honestly, in the vast majority of the cases is this. This is a case where the case that I presented, the angle is favorable for many things, but anyway, what we did was to perform OCT on left main circumflex, and we confirmed that there was really tight ostial lesions, but without much calcium, so no calcium modifications and no possibility to have a landing zone. So what we did was to perform, honestly, a non-compliant balloon dilation, and after having confirmed that the non-compliant balloon was well expanded and with some recoil, what we did was to implant a drug-eluting stent according to inverted provisional. We performed POT, and this is the results. Again, the concept of performing kissing is always discussed, but when we are dealing with a patient with a long potential history, we feel that to take care about the opening the door concept makes sense. So we dedicated attention to distal rewiring, and then what we performed was sequential kissing, putting 2 non-compliant balloons and sequential expansion of them, checking for the expansion in both directions, and then the simultaneous inflation. We performed also the re-POT and with the same balloon, and this is the result achieved, and this is also in the cranial view how the LAD looks. So it seems a quite predictable way of working. However, anytime we jailed a big vessel like the LAD, we like the idea of checking what's going on. So this is the OCT left main PCI that shows that there is a wonderful expansion of the stent where there was no disease, and also the fact that at the area of the ostium there is a good expansion and no jailing struts into the carina. So distal rewiring plus kissing balloon inflation is able. We also performed OCT into the left main, so again a very nice expansion. And this is the appearance of the LAD ostial ostium. What we used to do, you see that there was some plaque over there. What we use as a rule is the fact that we select for kissing the balloon that is sized according to the minimal diameter of the LAD ostium when we do on guidance, in order to open up the struts but minimizing the risk of dissecting the LAD. So, do we have alternatives? I will not come back. You saw that we have now, it seems that at least the side branch is very suitable for DCB, theoretically. So this is the other case I treated and I want to share with you. In my mind, it was treated exactly like this, like the other one. So what I did was to perform OCT into the left main LED because we want to know if there is disease that is unrecognized into these two vessels, and it is nicely open. So what we did, we performed again a lesion preparation with appropriately sized non-compliant balloon, and this is the results, however, that we achieved in these patients. So completely different condition. It seems that really it responded so well that, I mean, at this stage, if you follow what we did in the other case, we should have done a crossover stenting, a POT, a distal rewiring, a kissing balloon inflation, and a re-POT. So with this result, I really consider it as a good option to try to have to complete the procedure with a DCB dilation, with appropriately sized balloon, appropriate inflation. This was the final results. And honestly, I think that if you have a result like that, to spare all the manipulation that I anticipated in the other case might have some benefit, probably. Again, the OCT, honestly, we have no experience with performing OCT in DCB-treated patients, lesions. So what I did was to perform the OCT into the main vessel again. This was before PCI. This is after PCI. I want to emphasize the fact that there is, I mean, patency of the LED that is preserved. And so this means that if we perform the DCB up to the ostium, we will not expect to have systematically the nasty carina shift that is almost always induced by stent implantation. So it is possible that there is something, but it seems honestly not to be a major issue. You see here the indirect evaluation of the ostium that, I mean, sizes very well, honestly. So how to solve the doubt between these two completely different strategies? Again, the trials are the most effective way to have answers. So this is the study we designed. The aim is to assess the safety and the efficacy of DCB-only approach to Medina 001 bifurcation lesion in comparison to a single stent strategy with inverted provisional and, I mean, a possibility in favorable anatomy to perform ostial stenting if the operator is confident. The hypothesis is that a stent-free approach with DCB may provide superior clinical outcomes in this ostial lesion. This is the overall design of the study. The patients will be treated systematically by lesion preparation, including any type of plaque modification, but with a final confirmation of expansion of an appropriately sized non-compliant balloon. And then there will be the randomization to drug-eluting stent with inverted provisional suggested and ostial stenting allowed just when there is favorable anatomy, 90 degrees take off for the side branch and very good view to implant the stent, and alternatively drug-eluting balloon. So the study device are the Onyx Frontier drug-eluting stent and the Prevail, and that has now also an indication. So we will run in Europe this trial using an on-label indication for the DCB, and the primary endpoint will be net adverse cardiac events at 13 months, which is a composite of ischemic and bleeding events, because one of the potential benefits of the DCB is also a less dependency of the patients from double antiplatelet therapy in the case it is needed to stop. Thank you for your attention.
Thank you, Francesco. The role of imaging, is it image-guided or angio-guided?
So it is based on the attitude of the operators. So there is no mandatory use of guidance.
Any questions? Yeah.
So thanks for sharing the very interesting study. So that the randomization is after balloon angioplasty or before balloon angioplasty?
It will be before. The randomization will be after angiography, before we embark in the procedure.
Okay, so then
it is honestly it is an error. I realized while I was telling the slide it is
and
incorrect.
If that's the case, what is the definition of successful lesion preparation before DCB in this study?
So it will be possible to have the possibility to cross over. So I feel that the randomization before the lesion preparation is advisable because this also will understand how common it is to follow the concept of DCB. So I hope that there will not be a too high crossover, but to incorporate the crossover, I think that will make the strategy more, let's say, understood.
Yves?
Francesco, just focus on a point, just choice of the stent. I've seen in many stents and in bench, and when the angulation is 90%, and you stand towards the circumflex, some stents, they have a potential of deploying the ring, but some stents are missing the bridge, they are too short, and this is limiting the expansion of the stent in the curve. So it can be a good choice to go to see that in a bench with this stent. And a second suggestion is maybe Dr. Ikichi there. You remember he suggested to take a stent with the diameter of the proximal or close diameter of the main proximal segment in order to have this better deployment and avoiding this phenomenon of under-deployment in the curve.
So two well-taken points. Honestly, we designed the trial, but we asked Medtronic to run the trial, to support the trial, because we know almost everything about the behavior of the onyx stent in bifurcation interventions, because, I mean, all the visible art stuff and the bench tests that have been done let us know a lot of this platform that seems suitable for very large bifurcations and also with very large opening of the side branch. Regarding the concept of this platform, it is important because especially for the onyx stent, we have 4 different stent platforms according to the different sizes of the balloons. So, and not all have the same potential for expansion. On the other side, we incorporated in the last consensus document by the European Bifurcation Club the concept of looking at the chart of the stents, of all the drug-eluting stents, not only looking at the overexpansion, but also at the potential to have some underexpansion that can allow fit a large stent platform into a side branch. So, for example, the onyx stent, if delivered at 7 atmospheres, it is in the chart, it can be, I mean, much less as compared to the nominal diameter you have on the box.
Thank you and good luck with your study.
Thank you.
And the last presentation is from Dr. Sandoval, and it's recorded presentation. Please play.
Well, thank you for the invitation and opportunity to participate at this symposium. My name is Yader Sandoval, and a pleasure to be speaking here about physiology-guided side branch intervention with FFRangio. These are my disclosures. So let's just start with a practical case. This is what we see in our day-to-day practice, and this is a case now from a couple of years ago that really, when we started using FFRangio, really opened our eyes about the opportunities to integrate this into our clinical flow, to make clinical decisions about how to handle, bifurcation lesions. As you can see, this is, again, a day-to-day case, calcified disease, proximal inflow disease, metallurgy calcified disease, 010 LAD diagonal lesion, and we're thinking, how should we handle this case? You can see the FFRangio in the LAD is 0.73, and in the diagonal is 0.80, likely a part related to the inflow disease in the proximal LAD. We do some complementary intravascular imaging. This is calcific. We use intravascular lithotripsy and rotational atherectomy. And following that, we decide to proceed with provisional stenting of the LAD. Now, you can see here subsequent angiography. Now that large diagonal has been jailed. And of course, this is the area of debate and question. What should we do about a side branch that has otherwise good flow, that has an apparent lesion. This is, I think, the frequent dilemma in many of these bifurcation lesions. This is where, again, now angiography-derived FFR allows some opportunities to do this in a relatively facile manner without the need to use a pressure wire or hyperemia. In this case, we do FFR angio, and we see that FFR angio that was 0.80 now dropped to 0.64, and therefore now there's only not a visual angiographic anatomical concern, but now we have objective data, functional significance, informing us that diagonal, now has jeopardized flow. We therefore go ahead, again, this is pre-DCB era, we go ahead and convert to a reverse, a DK crush to stent technique and get a very nice result as demonstrated angiographically. But importantly, again, we're talking about modern use of physiology, and you can see how we use physiology at the beginning for diagnosis, during the procedure to guide subsequent interventions, and now post-PCI. And now you can see that the FFR angio now of the L18 post-PCI was 0.97 and the desired bridge 0.96. So now this is, in my mind, really how we can integrate opportunities for modern physiology for intraprocedural guidance. Now, we do have two great tools in the cath lab, such as pressure wires, wire-based, microcatheter-based FFR, and other tools that can allow us to assess the side branch, but particularly because we know that many of the side branch lesions do not have functional significance. However, the issue is that despite us having these tools, these are not commonly used. We just asked this question in the Progress Bifurcation Multicenter Registry, almost 2,500 lesions. And as you can see, a pressure wire-based assessment to look at FFR or non-hyperemic pressure ratio was only performed in 6.3% of lesions. So again, we do have some great tools to also be used in a cardiac catheterization laboratory, such as wires and other invasive tools, but these are just not used frequently enough. And again, this is how we enter this era now of angiography-derived FFR and how FFR angio may play a role in making some of these assessments in a more facile basis. Now, FFR angio was validated in a FAST FFR study by Bill Freer and Bernard de Bruin, showed a great sensitivity, specificity, and diagnostic accuracy for this particular technology. But an important point specific to bifurcation is that only 73% of the lesions involve the bifurcation, and thus we need more additional data in this particular population to understand how do we move forward. We've integrated FFR angio into a multi-center healthcare system now since 2023. We've done more than 700 cases, and therefore we're seeing a lot of bifurcations in which we're learning how to use these tools, and therefore that this led to this question of this study, which is being supported by SCAAR in part through a grant to Medtronic. And the question is, can we validate angiographic FFR in comparison to a pressure wire patients undergoing bifurcation PCI? So we have a small study for a diagnostic performance assessment, specifically trying to ask, can we understand physiology of both the main branch and the side branch, either provisional stenting or two-stick techniques, and also see if we can get some information on jailed side branches during the case as well. And the idea is to compare both FFR angio in comparison to the pressure wire. We have an ongoing single center study that I address in this here in Minneapolis, and which is pretty much patients reflective of routine clinical practice that are undergoing bifurcation PCI. And as alluded to, we're trying practically as much as we can to get data pre-PCI for diagnosis, post-provisional, and a final assessment if there was any other additional interventions at the time. And we're really looking at that agreement between FFR angio and pressure wire-based FFR assessments in these patients. And our aim is to get at least 34 well-curated, comprehensive assessments on both main branch and side branch in these populations. Thus far, preliminary findings were presented at SCAAR 2035 earlier this year. We've had 24 patients, mostly LAD diagonals. And again, this is preliminary data, not final. The final results will be presented at SCAAR 2026. But right now, this is some of the early signals that showed that there's a fair amount of modest agreement between these technologies. And we're particularly interested in see what's going to happen with that side branch, both pre-PCI and post-PCI, for us to understand whether this is a tool that we can incorporate to make decisions about remaining provisional or having to do additional interventions in the side branch. I think there's some varying challenges that we've learned through the experience. As I alluded, pressure wire-based assessments, particularly for comparisons, are just not used broadly in bifurcations. And we learned that it was just single digits in the Progress Bifurcation Registry. Even if you want to do a pressure wire, there's a fair amount of patients, 1 on every 10 patients, data from DK Crush trial, that you cannot get a pressure wire wire base into back into the side branch. There can be drift issues, and importantly, specific to FFRangio and angiography-derived FFR, is that we're going to trust these assessments and really make comparisons. We really need to make a proactive effort to reduce foreshortening, get a good angulation that will display that side branch in order to make calculations of that. So just to conclude, I think angiographic FFR has emerged as a facile approach to assess functional significance in bifurcation lesions, including main branch and side branch. Its accuracy, particularly compared to pressure wire, requires validation, and that's what we're trying to do, and I think additional efforts will be needed. And I think a particular group of interest is that jailed side branch, and whether FFRangio could be a particular approach that could emerge to really facilitate decisions about whether we can remain provisional or need interventions in that side branch, and hopefully we can move forward in this field. I will be interested in the thoughts from the audience. Thank you so much.
Thank you. Very attractive concept and technology. I would like to ask Jens for comments, and I cannot resist to ask also Prof. Ku, when and how to use this.
Well, when and how to use it, I think we need to introduce it and test it in practice, first of all. But I think it's really, really good that we have a validation study coming up, helping us a little bit more about understanding. We have been discussing the technology of the angio-based measurements before today. And one thing was actually the discrepancy between two of the projections and which kind of potential mislead that could introduce in the measurements. And this is one point. The other point is a study is important. But one thing that we learned in the past is that when we introduce a post-PCI measurement with FFR in the side branch, we impose a higher risk of dissections. So that means that by testing a system to see if it's safe, we introduce a risk in the test system. So there is some caveats in this study, but it's of course extremely important that we have them done and actually move forward with testing the technology.
Yes, so that I really look forward to the results of the study, but I personally think it's a very ambitious study because when we analyze any angio-FFR in non-bifurcation and bifurcation, we found that in bifurcation lesion, the accuracy is a little bit, less than non-bifurcation lesion. And I think it gets more complicated when you shift our focus to the jail branches, because flow dynamic and anatomy versus a pressure decrease relationship is quite different. And it's never been confirmed in this kind of studies. And when it is purely about the FFR-guided PCI, after balloon angioplasty, things will become more complicated because we don't know how to, draw the line with the dissection, so that it's technically very challenging. So we have to understand that, but we need to accumulate this kind of data more and more to see when we can apply quite, freely without any barriers of angio-FFR, and when we should use a pressure wire-based FFR. And we definitely need more studies.
Peter, final comments?
Yeah, I think it's fantastic. I mean, it's interesting from my point of view. I see that from DCB, it would be really lovely to be able to look at the end of the procedure and be able to measure non-invasively what our endpoint is. And that could be quite powerful because then we would, have a stop.
If it's ischemic vessel or not.
Exactly. But the hard thing, as you say, is to delineate the contour when you've got it really disrupted. So it'd be amazing, but if it's possible.
So we need second part with validation data next year, the same place. Thank you very much for your attention, and thank you to panelists.